So our next presenter is Dr. Adrian Lindsey. He's coming up from the back there. He is a hepatologist at MetroHealth, trained at UH, great friend of mine. Please give a warm round of applause for Dr. Lindsey.
All right, thank you for that wonderful introduction for me. Here we go. So we'll start. So most of the big things about the liver meeting was obviously the new hepatitis B guidelines that came out. But I'll kind of mix in some other abstracts as well, as viral hepatitis was a big feature, primarily with Hep B, Hep C, and Hep D for different reasons. So primarily with what part of this slide here is showing on the left for you guys, or I should say right, is going to be part of the reasons for why we are updating guidelines and things like that. So some of the biggest abstracts about hepatitis C is primarily about talks about improving access, people who aren't able to get it, primarily those of certain populations, primarily Native Americans, Native Alaskans, the incarcerated individuals, as well as different abstracts on how we can do the use of point of care testing and things like that to improve these accesses, as well as limiting the time frame between diagnosing and starting treatment. As we all know, we have to kind of do various different labs, testing to evaluate things, and various different forms of doing that. One of the big things, I guess, some of the big issues that were mentioned in the updated aspects of the hepatitis B was primarily improving the transmission, primarily more horizontal, I would say, is the greatest additions to the guidelines, more than the vertical, and then also a little bit of the changes with the screening. And I am also sorry that I did not include a disclosure slide. I guess I'm still in my training phase. I do not have any disclosures. As we get to the treatment, some of the big factors in this is individuals who we typically do not normally we're treating with the prior guidelines, especially the E antigen positive and negative, who were having normal LFTs, primarily the ALT, and moderately to lower viral loads. So I know this is kind of a busy slide, but some of the bigger things that we're kind of like mentioning is like considerations to consider treatment in these individuals. Primarily those who are having more high-risk features, which I kind of mentioned some of those things on the prior slide, but those who are having higher numbers of sexual partners, individuals who are using IV drug use as well, and these like higher risk individuals consider treatment. And then also, so when we talk about tailoring off in those populations, primarily when those high risk features are no longer in their practice. However you want to put that, but the biggest thing is like considering these individuals for treatment, especially if they want them. Another big thing that was also kind of like mentioned throughout the guidelines on these is age, primarily those who are older than 40, primarily for the HCC screening, which we'll kind of talk a little more about in the next slide as well. And then the third group that was another big thing is like with screening and treating individuals who are pregnant. It's like in the prior guidelines, it was kind of more of a the timeline within the pregnancy was a little bit more spread out between 28 to 30 weeks. 32 weeks you could start treating. Now they're kind of more stringent on saying it's like considered more at 28 weeks, especially in those who you don't really have prior status on. And then this slide here on the bottom, here on the bottom left is kind of some new data based upon a database of pregnant individuals who were started on treatment for hepatitis C, primarily the Sophia treatment treatment options. And in these individuals, they did show that they had higher rates of birth defects in the babies and a lot of other different effects, showing that probably we should delay treatment in Hep C after pregnancy. Now, again, most of these individuals that are in this database, they were not initiated treatment during pregnancy, but they became pregnant at some point, or treatment was started before knowing pregnancy status, and it was continued during that case. Another thing that I wanted to discuss as well with this slide is the role of doing a quantified Hep B surface antigen. And so there was a couple of abstracts as well as a talk talking about using this test as a risk stratification. So they're showing that individuals who had higher quantification loads had higher rates of HCC and risk of progression to cirrhosis, had higher risk of eventually over time developing ALT elevations and things like that. And those who had lower rates and lower loads were the individuals who tended to be able to be seroconverted and lower and not needing medication. And there was another one that showed that individuals who had lower, also when they came off medication, had lower rates of reactivation in the future. And so although it's not in the guideline, it could be something that we could potentially use going forward in the future. And so that's kind of why I wanted to highlight that on the top here, the different options and goals when you are talking with your patients about wanting to withdraw therapy, right? So we don't have a cure yet. Obviously, we're trying to do this. A lot of medications can help get you to the point where we have the seroconversion, or what we think of as a functional cure. And given the fact that, you know, when we're treating these individuals, they can be young. Not too many people like to be on the medication, one medication for 40, 20, 40, you know, up to an amount of years. So they're kind of doing that based upon your viral loads and things like that, and then also with co-infections with HIV, hepatitis D, and then you obviously want to do frequent monitoring in these individuals as well. Another thing that I did want to highlight, which we'll kind of like talk about more too, is doing these HCC screening. So before HCC screening was a little bit more preferred later on in the stages, but I was finding on more about early stage screening. And so here, when we talk about the HCC screening, again, like I said, the biggest things to add to this is the addition of other factors that are going along with these individuals. Because again, hepatitis B typically is not the only thing that can be going on, especially with the rise of MASLD and hepatitis B has been becoming a combined thing, especially over time. And it's showing that there is increased risk of HCC as well as progression of disease. And so that was also kind of part of the case in when we talk about treatment options for those when we're screening them with non-invasive testing, especially FibroScan, of considering individuals who have F2 with treatment and or screening. And again, another big thing is age is appropriate too. Here it kind of highlights the risk of HCC with the co-infection of hepatitis D, how that in itself will increase the risk of HCC, which is why even though we don't have if you have that co-infection, the age limit for initiating HCC is no longer there. And then another thing which I did not add on to this was the addition of the new studies of where we kind of trended individuals with Hep C after treatment, and showing that even though in our guidelines for HCC right now, we don't recommend treatment, or I shouldn't say treatment, but screening of HCC in individuals with F3 and below. But some of the studies are showing that years 4, 5, and beyond, there is a slightly increased risk. So individuals who are having these combined infections, even though we have cured the Hep C, kind of like evaluating that we should tailor that into the Hep C screening as well. Treatment horizon. So I didn't focus a whole lot on the medications because again, the biggest things that we were focused on at the meeting was primarily with the hepatitis B guidelines and therapies associated with that. But there are some medications that are going on. So this Tobevibart, I know, I'm sorry, I'm butchering that name. But it is a monoclonal antibody that attacks or is primarily focused on the Hep B surface antigen on the cell. So it's primarily focused on trying to block the virus from coming into the liver. And so the study with the Solstice trial is combining it with this elebsiran, which is mRNA virus. And so the goal is that we can not only just block the virus from entering the liver cell, but also to block it from replicating. And so that's the goal of this combined therapy. And primarily it's focused for those with a Hep D infection to help prevent the viral load of Hep B, but also primarily to treat the Hep D, because right now we really only have the bulevirtide. And so the studies are showing that with their space, it's not only just decreasing the Hep D, but it's also decreasing the hepatitis B viral loads too, and helping that to be an effective treatment. Another study that I really wanted to highlight as well was this abstract on the bulevirtide monotherapy and how it has been more effective, or just as effective, individual and safe in individuals who have cirrhosis, as well as people who don't have cirrhosis, which is a big game changer because again, right now most of the time it's more of a compassionate use therapy options. But it's showing that being more acceptable, more safe and effective. So it's helping us to expand our role in treating these individuals. Some of the other studies that I did want to highlight that I did not write down here was there was some good data about the association, not necessarily with statins and hepatitis B. So I know we've been seeing a lot of good positivities with statins with MASLD, statins with the association with possibly decreased progression of cirrhosis in MASLD, also with a possible decrease in HCC in these individuals as well, but showing that even with hepatitis B, there is also some shown to be some decrease with progression and mortality in these individuals as well. And there was also a study that I wanted to talk about too about different treatments for post HCC, where they did where they were comparing levulitide versus TDF and TAF, showing that there was really actually no significant difference in rates of recurrence of HCC after these options. I mean, obviously we mostly use TDF and TAF here in the U.S., but knowing that it's the fact that we have more than one options that are having the same rates of decreased HCC in these individuals means that we have a safe and effective and almost the same treatment options for these people as well, which is very good. Thank you.